or stethoscope placements, yeah. Upper, lower bases. If you see over there, it's got 3. Why it's got 3 on the back?
Reload.
Remember, you got a middle, top, bottom lobe. You saw the anatomy. I'm not a big fan of dissections either, but unfortunately it's there. Okay? Listen to lung sounds, because everybody remember the characteristics of the lung sounds, the wheezing, the rales, and all that stuff, because those are the things that we're listening for to be the abnormal stuff. What should we hear?
Clear.
It should be a nice windy day outside, right? Wind blowing and it sounds clear as can be. No obstruction. Checking pulses. Are they breathing fast or slow? Because again, those are symptomatics of, or symptoms of a person that's hypoxic. If they're hypoxic, they can be breathing fast because their body's trying to compensate, trying to increase oxygen level. Or they can be bradycardic because the body's trying to throw off carbon dioxide. Okay? Look for any symptoms of shock, confusion, inadequacies, things like that. Making sure that you're looking to see if there's anything that you need to do to fix this person besides giving them oxygen. Because again, they may have other problems, not just respiratory problems. So. And then again, transport is needed. Early transport, late transport, whatever. Now, when should you give an oxygen to a patient? We've already kind of said it. Walk in, see trouble breathing, oxygen then, right? Person's having a little bit of trouble breathing, maybe you can get away with assessing them a little bit first and then throwing some oxygen at them. Or maybe this patient's not having much problems whatsoever and you can give them oxygen and avoid them to the ambulance. It's kind of like the situation of what they're in at the time. So think about when you need to give them oxygen and when don't you give them oxygen. Give them oxygen regardless of what their symptoms is though. Again, toe pain still deserves oxygen. Get all your samples and everything like that. What's the PACE assessment? Posture, appearance, I don't know what it is either. Unfortunately, I put it on there. It's an assessment specific to multiple breathing. It's a patient that when you walk in, how do they look? How are they seating? How are they appearing as you're talking to them? How do they function when you ask them to do stuff? It's just a quick assessment. Again, I remember it says posture and appearance, but I don't remember the rest of the line. So anybody goes Google, please say it real quick. Not a look up and get next break. It's just another one of those mnemonics that you can use, but it's not really commonly frequently used. I've never used it before. And like I said, I remember it being on the book now. I don't remember it.
Pace?
Yes.
You want me to read what it is?
Yes, please.
Progression, associated chest pain, sputum, talking tiredness, exercise tolerance.
Oh, wow, that was all. Not the one I thought it was.
Page 607.
Thanks for bailing me out. I'll do hide in the corner now. Does that sound like something you're probably going to use that often? Because I can't even remember that one. You just said it pretty frequently. All right. It's one of those things where there's a lot of stuff that they talk about in this book as far as things you could do. Don't remember that there are some things you don't have to do. I mean, I would still, for the person that's having trouble breathing, that pace of the mind does sound like it's pretty good. Because again, you're looking at how they're functioning. Are they functioning under stress? Or are they functioning under active exercise? Something that could have been where they were affecting their breathing just from their normal everyday activities. Now they're having trouble breathing. They sit down, get a little bit of oxygen. Oh, I feel so much better. It's like a football player. You ever watch a football player when they go on the sidelines after running a big play and stuff? What's the first thing they grab? Oxygen. So look for signs of anything, especially for COPD patients. Now, COPD patients, remember, you got the rounded chest, you got the heavy accessory muscle use. Their ribs, I mean, they're fine-tuned machines because they have been so abused that they are working constantly. All right? So look for things that says, this person looks like they're struggling to breathe. Get their vital signs, especially, again, pulses, skin, and breathing is your most important. Mental status, because that, again, is an obvious first early function area that's going to have some problems with hypoxia. And then pulse oximetry. Now, pulse oximetry, what's the problem with pulse oximetry?
False readings.
It will give you false readings at times, because especially think about carbon monoxide. If that thing is looking at the red blood cell, and there's a 100% carbon monoxide attached to that red blood cell, pulse ox is going to tell you they got 100% oxygen. This pulse ox is sending a light down through the finger, looking at the size of the red blood cell. This says it's great. It doesn't see the carbon monoxide; it sees the red blood cell. How do you assure yourself that the pulse ox is reading right?
Do it yourself.
Take it yourself.
Okay, that would be an interesting thing to do. Let me lick your blood, see how much oxygen you got in. This works. Okay, pulse ox is on here. I'm measuring this. Pulse rate 64. Pulse ox says 64, 65. That's about right. Okay, so I can assume that I'm probably accurate there, but I'm not relying on it. What I'm looking at is other symptoms that the patient's having. And that's where we get into a situation with pulse ox. People look at pulse ox and then they will say 93, 94. Oh my God, this person's hypoxic. Throw oxygen at it. And it's still 93, 94. Nothing's working. What do I need to do? Let me throw the kitchen sink at it. It's not working. It's the pulse ox. Because trust me, I've got a pulse ox that told me I was near dead when I turned it on the first time. Because it was just a bad sensor. So don't rely on what I'm telling you folks. Don't use those things to say, hey, the pulse rate's 64. It's not always accurate. But what are they good about? If I do a 93 initially, and I put oxygen on the patient, now going up 95, 96, 97, that tells me there's some improvement, right? That tells me that maybe the patient can get a little bit better. I still got to worry about my patient's symptoms to see that they go away, but at the same time, it tells me that oxygen is getting into their blood. That's a good thing. There's other things you can think about as far as obstructions, especially with pediatrics, when you start talking about upper airway obstructions, infections, croup epiglottitis. And we'll hit pediatrics in January, but the things just be a heads up. Think about the airway itself. When we get them too, these are adult disorders too, not just kids, unfortunately. With epiglottitis, the infection of the epiglottis, that little covering that covers our trachea, that when we swallow something, it doesn't go to our lungs. With that epiglottis, if it gets infected, it starts swelling up, it starts closing off the airway. Or we start doing some stuff to try to make their breathing better by throwing airways in there, and we piss this thing off, it seals off because it gives it a spasm. And we can't get that thing back up. We can't go in and go, come here, come here. No, it's stuck. It's going to suffocate, right? That's not good. Epiglottitis is commonly seen in patients that have like a swollen back of the mouth, their tongue's very swollen, they say their throat's sore, and they have a raspy voice. Whereas with croup, they get their whole airway kind of swollen, and they have this like seal-like bark. When they cough, it's barking sound. And that's a really distinctive, you'll know it's croup when you hear it kind of situation. With them, everything hurts in their upper airway. The only treatment that you can give them is just humidified air for both of them. You have a water bottle hooking up to your oxygen tank, and then you're flowing the water, the oxygen through the water. You don't have to do it for 5-minute transports or 10 or 25-minute transports, but if you're going to be like an hour or so, you may want to try it because it will help soften up the tissue a little bit. But again, this is an obstruction. They're going to have where they can't get their air into their bodies. And this is something that, again, we need to recognize early and get them to the hospital for further treatment. Just talk about that. Here's the kid, the epiglottitis. Notice how her head's kind of leaning forward when she's trying to make herself comfortable. Again, it's swollen, it hurts. Now, pulmonary edema is the first adult disorder we'll talk about. What is edema? Okay, it's fluid. It's fluid that's in your lungs because it's pulmonary. The thing about it is that the blood is being occluded by this fluid inside the lung tissue. And the heart can't pump that fluid out of the lungs. Once it's in the lungs, the only way for that fluid to come out is this way, right here. We can give some diuretics IV-wise, and we can pee it out, because again, there are ways that the body gets rid of excess fluid. Breathing is the most common. It's easiest. The other way is you pee it out, the other way is you sweat it out. Those are the body's buffer systems. If those fluids keep developing, again, it's going to drown the alveoli. There's not going to be an exchange of carbon dioxide and oxygen. Instead, it's going to be drowning out the alveoli. So what we need to do is recognize pulmonary edema early, and we need to treat it early. So this video will show you, it shows you a good example of a guy having pulmonary edema. Listen to him and see his activity.
He tolerates the mask pretty well, if I remember right. 'Cause last time I talked, I treated him, he seemed to tolerate it well.
So what do you see as level of consciousness? Yeah, very out, right? Marginal. How about his work and breathing? It's very good, right? He's using accessory muscles, you know, so that down here, he's using a lot of diaphragmatic, lower abdominal, trying to get that breath in. How about his lung sounds? Did you hear them? Very crackers, right? Very nasty sound. Position-wise, they got him sitting up. Why? Yeah. Remember a guy, Isaac Newton, doing this work called gravity? Okay. Everything up here has to come down, right? So if the fluid's up here, we keep our bodies straight down. The fluid will start going down here. If it's down to the feet, do I care? Like a bigger shoe, right? If it's up here, I worry. You're going to drown. That's not good. So that's why we've got in position that we're an angle trying to get the fluid down low. Now, I don't know if you can see it too well with this image, but notice up here some swelling. This is called cerebral edema. Basically, it's the fluid has gotten up here where the body's trying to get rid of it, but it gets trapped in the sinuses. So they start swelling right around the cheekbones, underneath the eyes. This guy here, what are they going to? So much action. Where's the CPAP at, right? Because what's that CPAP hopefully going to do? Force that crap out. Blow that fluid out of it as best they can. So, very good illustration. And this, again, goes back to the illustrations. There's all this excess fluid trapped in these alveoli, sacs in the walls of the alveoli, and it's basically drowning them so that the oxygen and the carbon dioxide can't get the oxygen into the person. So, what are you going to do? You're going to give them high flow oxygen. Now, high flow oxygen, you can use a non-rebreather. You saw it on him the first thing. 5 to 10 minutes didn't work for him, so what did they throw it up to? CPAP, and hopefully that'll fix it. If CPAP doesn't work, then what are you going to go to? Bag valve, right? 100% oxygen the best you can. Maybe to suction them, because especially if there's coughing up some of that fluid and mucus and whatever else, you got to get it out of the airway, otherwise you're going to get an airway obstruction. This is a load and go patient because at your level, you can't do anything else. Believe it or not, at my level, I really can't do anything else. They took my diaphoretic from me. I used to be able to give them laces and drop some fluid out of them. Unfortunately, it took them an hour or two to pee it out. So we don't do that anymore. We can intubate the patient. You know, if we have to do some type of definitive airway, if they become unresponsive, they don't have gag reflex, we can start putting airways into them, right? So we can try that. Get them to the hospital. Now, position-wise, again, keeping them, setting up if they can, at an angle on the stretcher, 45 degrees. Take the feet, drop off the side of the stretcher. Use gravity to draw that fluid down to their from their lungs down to their feet as best possible. That's going to help their breathing. Now, we can drain all the fluid out. No, it's not going to happen. Their body has got that fluid in there. It's usually trapped, and unfortunately, it doesn't come out that easy. Same thing with COPDers. Now, patients with COPDers, these are your smokers, these are your patients that have been around toxic environments, smoke, chemicals, whatever else, and it's starting to destroy the alveoli, which is called anaphylactic. It was a long word, unfortunately. So, it can also start to cause bronchial damage, where the bronchioles get a bunch of mucus starting to build up on it from prolonged exposure to the chemicals. They get infections, and the mucus tries to block the infection and just keeps clogging them up. Okay? Big thing about it with emphysema is that you get the elasticity of the lungs to start going away. It gets really rubbery, so they don't stretch as easy. So thus they can't expand out and get air into them like they used to. Most patients with it have either bronchitis, which is the infection of the bronchioles, or they'll have some type of smoke, emphysema, the stretching of the lung tissue itself. So they're basically, their lungs are just damaged beyond repair.
So how has COPD affected the quality of your life?
You know, it's funny, over time, gradually I've noticed it being short of breath as first thing I recognized, I guess, is I didn't have a lot of stamina. Even when I was working and being very physical in the work that I did, I have to stop halfway up crawling up a ladder. And over the years, it's digressed to the point where I can't go for walks anymore, as much as I would like to. I have to take my time going downstairs, and especially coming back upstairs. You can't do the things that I used to love to do: play golf, ride motorcycles, swim, scuba dive. So all aspects of my life, it's other than reading, it's affected it greatly. Anything to do with being physical, because my lung capacity is just so diminished that once again I have no stamina.
So I know there's different classifications of COPD. Do you know how severe your COPD is at this point?
The only thing that I've read or I've heard people talk of is that it's severe. I don't know if there's numbers involved or whatever, but it's, in my estimation, my definition would be severe COPD.
So how was he breathing?
Not well.
Every time you talk, you've got like about 3 or 4 words out and then stop. That's that dyspnea I'm talking about, 2 to 3 word dyspnea. Because he had to stop, catch his breath, and then go a little bit more, stop, a little more. How did he appear?
Pale.
What type of body shape did he have as far as sunken? Kind of sunken in, really small. Looked like he's lost a lot of weight and stuff, right?
Right.
So, and most of your emphysema patients are going to look that way. They're going to look really thin because their body, again, is not able to send the oxygen out to perfuse the cells like it used to. Those cells are just dying, so the body starts to shrink. So we've got the normal alveoli over here. Good open area. Over time, with the exposure, the alveoli start shrinking down. They get filled up with mucus or infection, up to the point where now the alveoli start to expand. They basically are like a balloon that's overstretched. They get mucus involved inside of them, so now the air can't diffuse off to the blood vessel and get the carbon dioxide out of the body. It's retaining the carbon dioxide now. So, unfortunately, that is a big problem. Most of the patients, they have this swelling of the alveoli, and that stretching doesn't allow the carbon dioxide to fall off like it should. So they're retaining a lot more carbon dioxide. You may have patients that are wet lung versus dry lung. Now, the wet lung guy was the pulmonary edema guy, the one in the hospital. The rails, or the crackles, as that's called now, he was just so full of fluid, couldn't get out. Then you have emphysema patients that don't have that fluid, but they have a lot of dead space here. They have air that's trapped inside their lungs because the alveoli are spilled out. They have the infections, the mucus is trapping the air inside there, but it's just not fluid. So the question becomes, which one do you throw medication at, and which one do you not throw medication at? Because if you think about the albuterol and the nebulizers, and we'll talk about those here in just a minute, those are wet drugs. Those are drugs that is designed to weten the lungs. If I've already got a wet lung, do I throw more fluid at it?
No.
No, because I'm going to actually cause more problems. So albuterol, inhalers, nebulizers, they're only for the dry lung patients, the emphysema, bronchitis, asthma patients. And the reason, again, is we're trying to weten the lungs. We're trying to get that mucus wet so we can move it out of the way. We're trying to make their airways a lot easier for the air to go in. says as far as congestive heart failure, congestive heart failure is similar to pulmonary edema. The problem is that it's not, there's some type of toxic environment that's causing swelling inside the lungs. The problem is now the heart is backing up with blood and stuff, that it's trapping it in the pulmonary artery, and it's not letting it get out of the lungs that way. It's just blood and fluid there trapped inside the lungs. We'll talk about that next week. Pathophysiology-wise, with an emphysema patient, you're going to see this pursing of the lips. When they talk, you saw him every once in a while kind of like blue kisses actually. And that's a normal body response. They're trying to blow off that excess carbon dioxide that's trapped inside their body. They're normally going to be normal color. There's really no problem with their body color because their body, again, is thinking everything is great. So they're retaining some oxygen as well as carbon dioxide. Receiving wise, you're going to have them sit over, hunched over, trying to catch the breath. Appearance. That guy, you notice his neck very sunken in, face kind of sunken in as well. Really, for the most part, emphysema patients, they tend to last a very long time. Their body is able to adapt to not having that normal oxygen levels and working harder to breathe. It's only when they get a major infection or the medication is not keeping up and keeping that tolerance level that they really start having some issues. Especially wintertime, that's the best time for them. It's less air pressure and it's helping their lungs with some of that air moving inside. So, you got bronchitis patients, again, mainly that's just an infection of the bronchus. It's a buildup of the mucus, trapping the infection, and it just clogs up the bronchus. You ever had a upper respiratory infection? You ever been diagnosed with that? And basically, it's kind of the same thing. It's just a mucus jump buildup inside your bronchus. They retain carbon dioxide just like an emphysema patient. They don't have this stuff here. Instead, they have some of the trouble breathing, but they're not having the chronic issues. They're having some of the acute onset issues. Most times they're going to be cyanotic because, again, their body is not used to that sudden onset, and now I'm having trapped air in my body. What do I do now? And then congestive heart failure, like I said. Talk a lot more about that next week, but basically, again, it's a pump failure issue. The heart is not sending the blood out like it was. It's trapping some of that fluid inside the lung. Those patients, those are some bad issues. Because, again, you're going to need to get them to the hospital to get more definitive care. For COPDers, you're going to give them the inhaler if they've got it. They may have an albuterol nebulizer. You can try that. Giving them oxygen, but again, caution. Because these patients, emphysema, COPD patients, these are the hypoxic drive patients. And they may tell you, or they may not know, but you should be able to say, hey, that person looks like there may be a COPD patient. Use caution. I'm not saying don't throw 10 liters of oxygen at them. I'm saying use caution. If you start giving them a high flow of oxygen and all of a sudden they start to become a little bit more disoriented and tired and stuff, they're getting a toxicity. You're giving them too much air. Back it down, give them a nasal cannula. Because if you walk into a patient's house and they're on a house oxygen of 2 or 3 liters, using a nasal cannula, go to 4. Try that. Don't go above 6. Most times the reason they're on that low flow is just to keep them at that therapeutic level they need to be at. Any more, you're going to kick that hypoxic drive. The asthma, high fever, and allergic reactions. The main thing here is that with asthma, what is causing them to have trouble breathing? Swelling of the bronchus. Okay. There's some type of constriction. It's not an infection for the most part. Mucus is sometimes involved with the asthma, but most times it's just where the airways start to shrink down. They go into spasm. Allergic reaction, same thing. When you have a person that suffers an allergic reaction, their bronchioles, they constrict down. The body is sensing an outside invader and tries to prevent that invader from getting into the lungs, so it shrinks them down.
Asthma is a chronic long-term condition that can be managed but not cured. Asthma affects the airways of your lungs. It causes the airways to narrow and swell, resulting in wheezing and difficulty breathing. respiration, air goes in through our nose or mouth to the upper airways, at which point it reaches the windpipe, which branches into two large bronchi to reach the lungs. The lungs are protected by the rib cage, which also contains the muscles that control your breathing. In asthma, the airways are oversensitive and easily irritated by certain triggers, called asthmatic triggers. Most people with asthma are described as atopic, meaning they have an allergic type reaction to external triggers, such as house dust mites, pollen, cigarette smoke, animal fur, and chest infections. However, for some people, the onset of asthma is unpredictable and may be caused by anxiety, stress, or even laughter. An asthmatic trigger causes the airway walls to swell and the muscles around the airways to contract. The airways narrow, and breathing through them produces a whistling sound called wheezing. Mucus is produced from the lining of the airways, which clogs up the narrowed airways further and causes coughing. This makes normal breathing more difficult, producing symptoms of asthma that can be mild, moderate, or severe and life-threatening, where hospital treatment is needed. The narrowing of the airways is reversible if the trigger is removed, or if the inflammation is treated medically. Therefore, preventative treatment is used and can be managed by the patient themselves. An acute asthma attack requires medical intervention, but the type of intervention depends on the severity of the attack.
So we see a lot of kids having asthma. They're either exposed to some type of toxin that develops their asthma, or it could be just from outside invaders, pollen, bees, some type of aerial disbursement of something from little like dandelions when they develop these little white things with gold seeds and stuff like that, and nectarines that we call that. So we need to make sure that when we get an asthma patient, some of them are going to have the little pocket mask, the little surgical mask to cover themselves when they go outside, because again, they're trying to prevent those invaders from getting inside the body. Same thing with an allergic reaction. There's certain things they're going to be allergic to that once that trigger gets inside their body, it shuts everything down. And the only thing we can do is reverse that with the epinephrine injection. To try to slow it down, it's not going to fix it. It's going to slow it down, stop it for a few minutes. Eventually that epinephrine is going to wear off and it's going to kick right back on again. So the main thing with epi is once you give it, don't let the patient try to talk themselves out of going to the hospital. They still need to go into the hospital to get further treatment. And or maybe a second injection.
I do want to highlight to everyone what happens during an anaphylactic reaction, because there is a difference between just a localized allergen or allergic reaction and true anaphylactic shock. This word is key because your body literally goes into shock when you have one of these reactions. Now, it can happen with foods, medications. It can also happen with insect stings, with a bee sting, for instance. Because what happens is when you're exposed to this allergen, whichever one it may or may not be, your body responds to it. This allergen, your body recognizes it as a foreign invader. It attaches these antibodies. And what happens is these mast cells degranulate all this histamine. Now, if that histamine is just local, you might get a little local reaction. You might get a little bit of hives on your skin. But unfortunately, what can happen when it comes to anaphylaxis is within minutes of exposure to an allergen, food allergies, for instance, an anaphylactic reaction can occur where you get swelling of the mouth, swelling of the tongue and lips called angioedema. You can actually get constriction of your airways, making breathing more difficult. Your airways may constrict, but what happens is your blood vessels may dilate and you'll have a systemic drop in your blood pressure. As all these things happen together, if you do not respond, you can die. And I'm not talking die in hours. I'm talking within 10 minutes, if proper treatment is not given, someone can die. Now, What we have, luckily, is something called an EpiPen. This can be truly life-saving. This staves off what we call circulatory collapse. I want everyone to look at this label very closely. All you have to do is read. It's quite simple. You're going to pull off the safety release, okay? And then you want to put it into a bigger muscle. So the thigh tends to be a very good spot for that. And literally, you're just going to auto-inject into the thigh, hold it for 10 seconds, and then you're going to want to call 911 and get help. Because without this, and I have to ask the two of you, I'm assuming that your friends, you taught your friends how to use this?
Yeah, most of my friends know how to use it.
Because what you're going to see is if your friend, if your friend has anaphylaxis, they're going to have potentially difficulty breathing. You're going to see potential swelling of the lips and tongue. But if they look in extremis like that model over there, that's time. That's when it's time to grab the EpiPen. Well, thank you also.
So we'll hit this then when we get to immunology. Just basically, like I said, there's a bunch of cells in your body called mast cells. These regulate your homeostasis for the most part. And then if beta gets into these mast cells, it releases a chemical called histamine, and that's what sets the body off. So overproduction of histamine causes the bronchoconstriction and the vasodilation and all the other problems associated with anaphylaxis. So the epi goes in and it neutralizes some of the histamine to try to stop it from causing that chaos inside. Just something to look, I guess, forward to when we get to the immunological response and stuff. You're going to need to be aggressive with these patients. They're going to need the inhaler. They're going to need high flow oxygen to try to supplement their problems. Because again, they've got that restriction of airflow inside their lungs. True patients with severe asthma, you should not sit on the scene for more than 5 minutes with. These patients are going to be patients that you're not going to be able to control nor probably properly treat. They need further steroid treatment in the hospital. The albuterol stuff is very limited. I mean, it goes for 6 or 10 minutes per dose. And you've got usually 5 of those doses for you to give them around to the hospital. So, 30-minute transport time, you'll have enough. But the problem is that they're so tight and everything like that, the medicine may not be able to get into those lung tissues and start that constriction reversal and stuff. So we need to get them prompt transport as quickly as possible. Anaphylaxis, again, the EpiPen is going to be the GI thing they're going to give those patients. You may still give them an albuterol treatment after the EpiPen has been given to try to help with some of the bronchial issues they're having. You've got a condition called pneumothorax where the hole inside the lung tissue develops. And this is not from trauma, this is from patients that have asthma, believe it or not. Maybe they have a weakening of the lung tissue and they just develop these little holes in their lung areas. And they basically start to have that air escape in their lung tissue, get into the chest cavity, and then start putting pressure on their lungs. So where now the outside air is now going inside the lungs and then right into the chest tissue. And it starts to cause the lung to start swelling, get closed off to the point where it can totally occlude. When you've got these patients that have pneumothorax, the only repair is to take them to the hospital and they do chest tubes. And unfortunately, we can't do that. Now, we can do chest tube compressions where we stick a needle in the chest wall, and that will relieve some of the pressure, but it's not going to fix it. That's only at an ALS status, a paramedic. It's usually lung infections or weakening. Cystic fibrosis patients, they develop spontaneous pneumothorax all the time. You're going to be having trouble breathing, you listen to the lung sounds. I mean,